So the first one is the lymph node of Cloquet. A lot of you had answered it correctly, so I would not really take a lot of time there, but I'll still explain because some people felt that it wasn't very clear. So remember, the significance of lymph node of Cloquet is related to the block dissection that you do, Eiling-Wanner block dissection. And actually, Eiling-Wanner block dissection is commonly done for cancers of the penis or cancers relating to the scrotum or cancers involving the lower limb, which could be squamous cell carcinomas or melanomas, depending upon, whatever. So basically, you all are aware that we divide the inguinal lymph nodes into superficial group. The superficial group is superficial to the camper fascia, right? So it'll be camper fascia covers the femoral vessel, so it'll be superficial to the D fascia that you all know. So it is superficial to the Camper's fascia. The other name of this lymph node is also the lymph node of Rosemuller. You also have a fossa of Rosemuller. No, you all know that. That's in the head and neck. One of the sites, the blind sites where you may miss on triple endoscopy, the primary. So this is also called the lymph node of Rosemuller. Where was I? Yeah, here. So usually it is superficial and they could be up to 2 centimeter size of the node it can achieve because they are often involved in infections of the foot, barefoot walking, and see barefoot walkers would generally have, I hope I'm legible, I'm trying to make it as clear as possible. So they can have this. So usually you remember 1.5 and 2 centimeter. One is cervical group of lymph nodes, 1.5 is the axillary group of lymph nodes, and 2 centimeters is the inguinal group of lymph nodes. So we have the whole idea is to understand the logic, right? And the purpose is to understand the concept of why we divide them into various groups. So superficial to the campus fascia. It can be actually mostly in the upper part, and they are usually palpable. And they can be palpated in most people, especially, as I mentioned, barefoot walkers. The deep are deeper to the campus fascia, and they would be I'm just trying to move to the next page. Now, okay, so superficial to Camper's fascia, and up to 2 centimeter can be a normal size. But in the presence of a primary, it will be significant. If it is hard and fixed, it will be significant, etc. Now, there can be the nodes which are deeper to it, and they can be usually along the vessels, and most commonly along the femoral vessels. That's why we look for dissection in the Eiling-Wanner block dissection. We look for the medial limit being adductor longus, lateral limit being sartorius, and inguinal ligament being the superior limit. But we must expose the fascia that is covering these vessels. So that is what is to be understood. Now, the superiormost, the medial most, and the uppermost lymph node is the lymph node of Cloquet. It was once upon a time also taken as a sentinel node for cancer penis. And a lot of people feel that this is usually the first group of nodes that gets involved. Colors. So we normally have the vein, artery, and usually all of you are familiar with the mnemonic: navel, nerve, artery, vein, empty space, and the lymph node. And that lymph node is a lymph node of Cloquet. And this is the medial limit of our dissection when we are doing clearance for ileum-guanal block dissection, especially the inguinal part of it. So that I think is easier to understand. Moving on, it is also considered the lowest lymph node of the external iliac group. So if I can draw it for you, when you're looking at ileum-guanal block dissection, usually we take the upper limit as this, the aorta is bifurcated, and then the common iliac bifurcates into the external iliac and the internal iliac. There are nodes along this. And external iliac continues down as femoral below the inguinal ligament. So this, therefore, is the lower limit of lowest. I mean, if I can use the term, the lowest external iliac group of lymph node also. So I've given it its due in terms of its importance in this is internal iliac, and that's the superior limit of block dissection. Now, the block dissection, I'm trying to use another color so that you're able to understand more clearly. So this is my limit. It starts from the bifurcation of common iliac. Medially, the nodes keep going down, right? Medially, it's the bladder, which will be somewhere here, right? And laterally is the genitofemoral nerve, which will be somewhere here. So this entire thing is to be dissected in the iliac part of it, and lower down it's the adductor longus and the lateral limit is sartorius. So you need to, I'm sorry, that's rubber, sorry. Okay. So that's roughly to let you know the crossing of the muscles, and that becomes the boundary, and this is the superior. So that's superior part and inferior part. So ilio-inguinal block dissection. So that's the significance of the lymph node of Cloquet. I'm sure there'll be questions. If there are any questions, you can keep typing in the chat box. I'll take them later. Now we are talking about maybe we can take the next question. The next question was?
What is a criminal nerve of Grassi?
Okay, that was a recent one. Yeah, that I gave recently. Criminal nerve of Grassi. A lot of you have answered beautifully. So I'll just quickly run through it, which will be easier for you to understand. So first of all, let's draw the stomach and understand the anatomy. The purpose was to check whether you actually understand how does the vagotomy help or does not help, what does it do, etc. I'll use a yellow color. Usually the trunk, the main trunk, would divide into an anterior one, which is actually the left. People confuse it. It is left because of its location, and the right is the posterior is right. So kind of a misnomer, difficult to understand when you draw it. So what I'll do is I'll try to make them into different colors. I'm changing the position so that you're able to understand. All right. Now, it kind of pardon me, I'm not trying to make it difficult for you. So divides into left and right. So let's, rather than left and right, understand them as anterior and posterior. Then you will have no issues. Anterior and posterior. The anterior gives off a hepatic branch, which naturally goes to supply the liver, the gallbladder, and gives off a pyloric branch, which ends here, which is actually responsible for the, that's the pyloric branch, which is responsible for the pyloric opening. So therefore, whenever you do a truncal vagotomy, you have to do a drainage procedure, because I've just joined it with the same color, doesn't matter. Now, so if I cut it here, the nerve is divided already. This is the other one. If I cut it here, I'll be cutting off the hepatic branch as well, which will lead to denervation of pylorus, and that will lead to lack of drainage. So therefore, we need to add with it a drainage procedure. I'm talking about, say, if you done a truncal vagotomy, then you need to add something to it. Either you make the pylorus wider, that is called as pyloroplasty, or you do what is called a gastrojejunostomy, which you've all heard. TVGJ used to be a very popular operation in the past. Not very popular now, because we are able to manage with drugs. So it doesn't, peptic ulcer surgery is not very popular these days. So I'll move on to showing you the purpose of understanding this. So therefore, there is a concept which is called as truncal vagotomy. If you're doing truncal vagotomy, now I don't need to tell you that you need to make sure that you do a drainage procedure. I'm now drawing it maybe better. So this is continuing down as anterior nerve of Letaget, and the last 7 to 8 centimeters of the pyloric region, it ends up like the foot of a crow. So it's called a crow's foot, which is very close to where the prepyloric vein of Mio is also going. So you're familiar with that. This is again to show that it is given off a hepatic branch, which gives a pyloric branch here. So this is important to preserve. If you can preserve this, then you don't need a drainage procedure. Now, what is the course of the posterior one? Posterior also is parallel to it, but it's to the right of it. I'm not able to draw that right here. If I draw it here, it will not make sense. Now, it is also continuing down as posterior nerve of Letaget, after it has given off a branch to the celiac plexus, which is a celiac branch, that is called a solar plexus because it looks like sun. So that's a celiac branch, and it also gives off at the gastroesophageal junction a nerve which can be missed. Now you see both of them, actually now I'm showing you the parietal branches. Both of them give off parietal branches which supply the P cells which produce acid. This is from the posterior one. Now they're all supplying which cells? P cells, which produce the pepsid and of course the acid related activity. That is what is responsible for all the acid, and both these continue down as nerves of Letaget. There is an anterior and there is a posterior nerve of Letaget. As simple as that. The anterior nerve of Letaget, I have already shown you, forms the crow foot here. So people were getting smarter, so they thought they will do just a selective vagotomy. Why cut these trunk? So if they were doing selective vagotomy, they were not successful to the extent they needed to be, because this criminal nerve, that's why it's called criminal, it'll escape detection and it'll be supplying the fundus, and there'll be recurrence of ulceration in this zone. The same was true of highly selective vagotomy. So there was a truncal vagotomy, selective vagotomy, and highly selective vagotomy. Now, this would require drainage. This is not popular because, you see, if you are missing the entire denervation, if you're not able to do, the outcome would be poor. Highly selective was considered a very technically demanding surgery where you will be cutting off all these branches, right? You can't miss any. But even in there, the criminal would escape, and that would cause recurrence. So most of you have written only in highly selective vagotomy. It was true even in selective vagotomy. When you read the literature, you would find highly selective vagotomy, because selective vagotomy was never a very popular procedure. I hope that is clear. So when you're doing truncal vagotomy, you will do a drainage procedure. Why? I've answered that because this is a commonly asked question, which you should know, because you are indirectly, inadvertently, you've heard of a cholecystitic heart. Same thing, because vagus is supplying there's a cystic branch from hepatic branch. Cholecystitis can lead to vagal stimulation and bradycardia. That's cholecystitic heart. So they're all related because of the vagal supply. And pylorus is controlled by this pyloric branch, which is coming from the hepatic branch. So if you cut above that, then you're likely to produce drainage problems. So you need to, therefore, need a gastrojejunostomy or pyloroplasty. So this is the understanding of the concept, that is truncal vagotomy, selective vagotomy, and highly selective vagotomy. So the issues were highly selective vagotomy, if I may pen them down. Technically demanding. 2, it could produce, along with denervation, ischemia also. Because, with you're cutting off here, so you can actually end up cutting off the blood supply to this place also. So this could produce ischemic spots. And 3, you could miss the criminal nerve of Grassi, which can lead to recurrence of what? Peptic ulcer disease. These are the 2 questions. If there is anything after this you want to know, that will be covered. Now let's go to the question asked by our colleagues. Now you'll have I promise you, whatever happens, the Gurukul webinar would continue and you'll have it every week. Let's go to the questions that have been asked. Sukriti.
Yes, sir. A postgraduate student asked this question, sir. Would kindly elaborate on triple assessment for breast diseases, for breast disorders, and specifically in context with imaging, and also for thyroid disorders.
Triple assessment. Well, I think I have a complete video on this on the on YouTube, but doesn't matter. I'm never tired of repeating it for the sake of my students if they are not following it. Remember, it is 3 tests, and there is a system of even evaluating triple assessment. I mean, triple assessment itself getting evaluated. Let's not go there. So it is for you in the exam, thorough history plus clinical examination. Very important. And to that now, with the AJCC 8th edition, clinical examination is associated with ultrasound for axilla. If you don't do ultrasound of the axilla, you cannot clinically, that's not a complete clinical examination. So it should be clear. Thorough history, which includes family history, treatment history, reproductive history, everything. Thorough, therefore. Don't use the term history. History is an incomplete term. Thorough history. Clinical examination. In sitting, supine, and reclining position. Sitting is ideal for inspection. You see, you will be able to see better. You can see both sides. You can actually look for the level of the nipple areola complex. You can look for any dimpling by asking the patient to lift up the arm. You can look for any, missing of the in the intramammary fold, any lesion, or because you can lift up and see. And generally you can see if there is any fullness or scars, sinus, etc. But this is mostly, I'm saying, it's not that you cannot palpate in sitting position, but this is classical. And you would be standing in front, so you're at the same level as the patient's breast, so you're able to see it much better. The fullness, also any signs of, that is any erythema, any scars, sinuses, it's all very, very clearly seen. Supine is ideal for palpation. Why do you think so? Why do we say that supine? Because it's easier to palpate any lump against the chest wall. And you know what? The moment the patient lying supine, the breasts tend to fall outwards. And as they fall outwards, it is easier to palpate for any lumps. So you can palpate better because you're palpating against a hard surface. You can palpate in sitting position also, but just a matter of reinforcing that it is required. The other thing which I probably didn't mention in the standing, or the sitting position, was that supraclavicular fossa can be seen more clearly. And you can also look for the infraclavicular fossa and infraclavicular nodes. And where do you look for the infraclavicular fossa? We can actually look for it by looking at, see, I'm trying to draw something, hope it makes sense. You have the deltopectoral groove. Pec major is going like this. So there's a groove here, which you can feel in everybody with the arms by the side. If there is fullness there, and if you can see a vein there, suspicious of infraclavicular lymph node. But that's just to let you know. But usually you're able to palpate it better in a supine position. And why have the reclining position? The reclining position is when you want the advantage of both. You have only one position that will have a combination of both the sitting and supine position. So it's a very useful position, reclining position. And how do you palpate for breast? You can have various methods. There is a method called dial a clock. This is usually how you demonstrate. Sorry, I can make it better, but just to completely cover, this is axilla, that's how we'll show it. People divide it into quadrants, which is not correct because they are not quadrants per se, because they're regions. This is the central region. Then, of course, this can be called outer quadrant, inner upper quadrant, lower outer, and of course, the inner lower. And that's the tail, axillary tail of Spence, which you should try to palpate for. And then there is axilla. Now, usually the central region is palpated separately. This is there in my video, where you also look for the nipple for the ducts, any discharge, etc. You can, by rolling, you can roll between the fingers and feel for it. You should not miss it. Dial clock is, the advantage of dial clock is you can actually mention at 2 o'clock, 11 o'clock, 2 o'clock, 4 o'clock, etc., rather than being vague. Because if the lump is small, you can actually describe it in the form of a clock, and you can actually make it 12 o'clock, 6 o'clock, right? 12 o'clock, 6 o'clock, 3 o'clock, and 9 o'clock. And this is the central region. That's how you go for it. Okay, so that's the clinical examination. And now I mentioned about axilla. There are various methods of doing it, but I prefer to put the ipsilateral side. Suppose I'm doing on the right side, right? I'll have to put my left, this is the right side. So I will put my right hand on the right shoulder. So right hand on the right shoulder to stabilize it. And the forearm of the patient rests on my right. This is my hand, okay, trying to show it. So what that does is it relaxes my left hand is now completely free, and I can palpate for all the groups. So that's the examination. Plus, you will have to add ultrasound now, as I mentioned, according to the AJCC 8th edition. It is clinical examination plus ultrasound before I call it N0 or N1 axilla. So that's about the thorough history, clinical examination. Then is imaging, and that's where probably somebody is asking for more emphasis. So I'll quickly take it. Now, imaging, remember the gold standard is mammography. So don't confuse anything. There is no confusion about it. Bilateral mammography. But mammography has its limitation. It's the most sensitive test, actually. Also, very specific, more specific than MRI or any other investigation. Now, mammography is basically, you know about the BI-RADS grading. I would also urge you to watch my YouTube video on triple assessment. So there's something you must do rather than just questions. The BI-RADS, you can put the BI-RADS grade and you can actually know. Now, the issues are when the breast is dense. The dense breast would look, white. Fat looks black. The lesion looks white. So naturally, which one would be better for mammography? I'll just change the color so that you're able to. Now, fat, black, lesion, white. So naturally, the ideal breast for mammography is fatty breast. But if the breast has more parenchyma, it will be white itself. So to see white against white could be a challenge. So in a dense breast, you have to then look at options. You can do ultrasound, which is done in most cases anyway, in patients who are younger and have a denser breast. It's important to understand it's not just the age that we talk about. So less than 35, ultrasound. More than 35, this is for you to remember, which is easy, mammography. Now you've done both. And what do you do for somebody who's 35-year-old? That's a good question. You can do both. And a lot of people like to now do sonogram and mammogram. Some people like to call it breast X-ray. So these are terms basically for you to understand. So preferably for a younger breast, which is denser, it is not about the exposure part only. So don't get confused. Just because X-ray has mammography has X-ray, so younger patients should not get it. That's one reason, all right. But the main reason is that it will have poor sensitivity and specificity because there is an issue with the white against white background. So you will do an ultrasound for denser breast. And where will you do MRI? MRI is very useful if you have a confusion. You have equivocal results with both mammography and ultrasound. And in especially dense breasts or those with implants. And some people would talk about it in picking up the multicentricity, so lobular carcinomas. Some people would get down to the level of BRCA1, BRCA2 positivity. So the other reason why BRCA1, BRCA2 positivity, a lot of people like to do, even screening in US, they would like to do an MRI because it has been observed that mammography can precipitate cancers in the in situ lesions becoming invasive. Well, don't get lost here. The idea is simple. For you to understand mammographies, bilateral mammography is the investigation of choice for most women with breast cancer or suspicion of breast cancer. And if they're more than 35 and the breast is not dense. If it's a dense breast, mammography may miss out on account of white background and the lesion being white also. So you can go for ultrasound or you can go for MRI. I often say MRI is an ultrasound of a rich person and ultrasound is an MRI of a poor person. But actually that's a very, very blanket kind of a sweeping statement. MRI is very useful for a lot of patients where you're planning breast conservation following Patient has received neoadjuvant chemotherapy. A lot of people use it for assessing response because it is picking up, it's very sensitive. But the flip side of this, the MRI for assessing response, that is for racist criteria, which response evaluation criteria in solid tumors. So MRI is useful as in equivocal situations, dense breast, patients with implants, patients with BRCA1, BRCA2 positivity, also lobular cancer, etc. Now, familial cancer, I wanted to say that when I was saying BRCA1, BRCA2, and also I've talked about mammography-induced cancers. That's something where even for screening, people prefer using the MRI. The other advantages when you're assessing response to neoadjuvant chemotherapy, and although it's not mandatory to have MRI before you plan conservation, but a lot of people like to pick up the multicentricity, which can be a contraindication for doing breast conservation, because mostly breast conservation should be done if through one incision you can get the entire lesion out. And if there's multicentricity, they're all confined to one, it's multifocality that can be treated. And the definition of multicentricity is now more than 4 centimeter distance between the two lesions. It's not the quadrants or regions anymore. That's again AJCCA tradition. So that's about the usual imaging. And a lot of people, like as a routine protocol, follow it. What is a major problem with MRI in any region of the body is that surgeons find it difficult to interpret. They find it easier to interpret a mammography or an ultrasound. So subjective, but it can't be put against MRI. MRI is a useful investigation, but remember, it is very sensitive, but not very specific. So what that does is it will pick up too many artifacts, and that can increase the rates of mastectomy. So it has been observed in many studies that wherever MRI was used, mastectomy rates increased, because a lot of lesions which may not be cancers per se, although you would still like to go for the third part of the triple assessment to confirm it, but there's a likelihood that one would err on the side of not operating, not doing conservation. Right? Mastectomy rates would increase. So MRI is not very useful for those situations, but certainly it's not mandatory for doing breast conservation. It is used to basically pick up if it is a multicentric disease or not. The third part is histological diagnosis, and don't call it cytological diagnosis anymore. FNAC is no longer on. It's not done. It is core needle biopsy. Don't call it true cut biopsy, which again is the wrong term. That would bring in the the trade name. So core needle biopsy. Why is that better? Why is that superior? First thing is it gives you the tissue. It gives you cells. So this would have higher false negative rates. You may miss out. This will have lower false negative rate. So it's more sensitive and specific. It can pick up now I think it stops here because there's nothing it can pick up beyond this. The grade. Very important in the management. And then it can pick up the biomarkers like ER, PR, HER2 new, Ki67. It cannot pick it up. It cannot pick it up. So there are two major disadvantages. It has got false negative rates. You may miss out. Negative FNAC has no meaning anywhere in the body. It's a positive FNAC which counts. And then biomarkers, which are useful for carrying out planning of the treatment. All treatments today are planned based on the biology. And this is the biological classification. Important. So we would like to do a core needle biopsy. Is that enough? Again, I'm qualifying. Image guided. That's a recommendation. And you should not be surprised. Sometimes you can argue that there's a large lesion why bother? But you can still be hitting the necrotic area or non-representative area. So your answer in the exam should be image-guided core-needle biopsy. That will tell you all these features that I was referring to. The important thing which I left it here specifically for the sake of students to think was that this will pick up in situ disease also. Do you know in situ incidences increase with screening? Screening because in situ ductal carcinoma in situ would be microcalcifications to pick up. This will not pick up. No in situ. Naturally, because there is no tissue. Actually, in the first line itself, everything is answered, right? Because you have cells versus tissue, which makes all the difference. With cells, it's likely to miss out. One is likely to miss out the cancer. Two, you wouldn't know the grade. You would not know whether it's crossed the basement membrane or not. So it's in situ or invasive. So it'll pick up in situ and invasive very easily. It makes a difference. Finally, lobular carcinoma in situ is not taken as no cancer. It is just a high risk for cancer. So either they are kept in surveillance or they're put on tamoxifen prophylaxis, etc. In their cases where then you go for genetic workup, family history, etc., all those details. So that's about the triple assessment for breast cancer. Now let's take the other one was thyroid cancer, where also you do triple assessment. So first part is thorough history, including family history. Here you will have, now we know there are genes for, there of course there was a gene for medullary carcinoma of thyroid, which is which you all know is red proto-onco gene. And you'll take a family history for papillary also. Now we are looking at genes, and also the highly aggressive papillary cancer has a gene that you will all answer in the chat box. I've taught you all. So, which is responsible for picking up the tumors that won't be responding to radio, that won't be, they'll be not be avid to radioactive iodine. Which gene is that? That's a question. You can write in the chat box. I'll see who writes first. Now, that's about the medullary and papillary. Already somebody has written BRAF mutation is correct. And that actually mandates, that's fine. All of you have answered it. Now let's move, otherwise your focus would go. So we'll take a good family history. And in addition, we'll take a history relating to, when you are mentioning the history, always call it MEN related disorders. So good family history, thorough family history, including the complete history, including the family history. That's what you need to be doing. Correct? Now let's move. Code examination, part 2. So where was I? 1, 2. Clinical examination. Again, you will describe that, examine the patient in a sitting position, in good light, with me at the same level as the patient. Okay. I think you can read it all. And I'm hoping you can, because I can't read what I've written. You should be able to make some, I am speaking, I am writing. So hopefully you'll be able to understand. So anything that's not clear, do ask me at the end. Don't worry. I'll answer all your questions. In good light, don't say daylight, because no patient is examined sitting outside anymore. Just good light. Sitting, inspect from front, palpate from behind. Inspect from front, palpate from behind, except trachea, which you palpate from front. And when you are inspecting, inspect first from a little distance so that you can pick up minor swellings or any anomalies, minor anomalies. From a distance, then from close. Palpate usually from behind. It's in the thyroid fossa. Any swelling in the thyroid fossa, which has boundaries like sternomastoids, on both the sides, suprasternal notch here, and thyroid cartilage here. And you know, the ligament, the pretracheal fascia is attached here. So the swellings of thyroid don't go above this, because that's where the ligament of Berry is, which is nothing but condensation of pretracheal fascia, and thyroid is within that. So it cannot go above the thyroid cartilage. That's why this is the fossa. When it goes above, it's basically pushing the fascia up. That's the, and it's a false capsule that the thyroid has. So it hangs like it hangs in a bag. So it kind of encircles it, holds it up. And parathyroids are extracapsular. They're not in the capsule. Therefore, when you do capsular dissection, you throw the capsule down, parathyroids will go down. That's why capsular dissection is required for protection of parathyroids. That's the basic understanding of thyroid, okay? So it's like, it's like an envelope, which is ending here. This is the thyroid cartilage, ligament of Berry. That's the bag and the gland is in it. So when the laryngo tracheothyroid complex on swallowing moves up because of the inferior constrictor, moving up, it goes up like this. This is it. It's the easiest way to understand it. So when it becomes a very large goiter, it keeps on expanding, expanding, expanding. So when it goes up, the effort is huge. That's why on swallowing, the patient has discomfort. It's not dysphagia. It's discomfort on swallowing. Dysphagia is when there's a pressure. Esophagus is not compressed by the thyroid swelling. So therefore, don't get that idea wrong. In the exam, I often hear students saying there is no dysphagia. How would it produce dysphagia? First, the trachea will come. It will kill before it causes dysphagia. Won't it? It will block the trachea, then it will block the esophagus. So this is not dysphagia. It's basically just a discomfort on swallowing. So patient, because it's like when you're swallowing, you're lifting up a brick, and then you start lifting up a bag full of tomatoes, and then a rucksack full of everything. So naturally the discomfort. Anyway, so examine properly. Look for everything. I'm not covering that here. I've taught this many times, examination of thyroid. Second is imaging. So good history, examination followed by imaging. And we must do high resolution ultrasound. Your answer in the exam should be high resolution ultrasound. This is important to pick up whether the disease is bilateral. It is whether it's heteroechoic, which means the echogenicity is variable. So that can be suspicious of malignancy. It will tell you whether there is blood supply increased. Suspicious of malignancy. It will show you whether the capsule is breached. Suspicious of malignancy. It will show you lymph nodes. If they become spheroidal, not spherical, spheroidal, three-dimensional. And when they breach, this is when the capsule is visible. It is called a halo. When it is breached, this is called the halo sign. It will show the fatty hilum getting completely replaced by the blood vessels, and the shape changing from oblong to spheroidal. I've already shown you. Bean shaped becoming spheroidal. Some people also call it kidney shaped. Then you're asked, what is kidney like? You say it's bean shaped. And you're asked, what is bean like? You say it is kidney shaped. Then how are they both? So they are like each other. This is confusing, right? Oblong means oblong. And when central necrosis keeps failing, it kind of becomes spheroidal. That's one way to understand it. Anyway, it'll show you the lymph nodes. So it'll show you all the features, which nodes, and also the vessels. So it's a very, very useful investigation. And you can add elastography to it, which is also given in some of my videos, YouTube videos. Elastography can also be graded. Now, naturally, the harder ones are less elastic. They're more likely to be malignant. So you can add elastography to it in the form of imaging. And following this, actually the triple would mean FNAC. You can't do core biopsy here, unfortunately, just a contrast from breast. And I'll tell you why. But before you do an FNAC, always mention thyroid function test. They don't fit into this. So what do? FNAC following thyroid function test. Why are they mandatory? It is very important to get the TSH level. Because if the TSH is low, which means toxic gland, I'm dealing with a thyrotoxic situation, right? And if I poke in a needle, I may precipitate a storm, what is called as a thyroid storm. Or I can pick up some, proliferating cells or atypia, which can give me a false positives for cancer. So one is a thyroid storm, the other is false positivity. These are the two disadvantages. So you should not be doing it if the TSH is low. For that, you need to do a TFT. Okay. Now this is triple test and FNAC and imaging. Now, high resolution ultrasound is graded using what is called a TI-RAD. You will have various grades, TI-RAD 1, 2, 3, 4, 5. To remember clearly, for the liver, we have LI-RAD. You can have for prostate, PI-RAD. Easy to remember. But we are here, TI-RAD. Okay. So that's about the imaging. For FNAC, we have various systems, but Bethesda is what a lot of people follow. Grading. This is necessary. Please do read it. It's there in my YouTube videos. So that's about the triple assessment for both breast and for thyroid. Next question, Dr. Sukriti.
Yes, sir. So what is taxis in hernia and what are the controversies related to it?
Well, see, we are jumping from breast to thyroid and now to hernia. Taxis is nothing to do with taxi. So a lot of people answer that question in the exam. Like it's like taking a ride. No. Taxis is basically related to reducing hernia. Very commonly used in terms of hernia, as we talk. Taxis is used it's an English word. You can use it in many places. Now remember, in order to do taxis, the best thing is to ask the patient to do. Remember the principle of examination, any patient that you examine. Always do the active test first. That is, patient does it. And don't do the passive first. Passive should be second, which is what you are doing. Because patient would know how to do it painlessly and effectively. You will, when you are doing it and if it is hurting, it would be bad. It's considered bad method of doing it. It's not correct. So active is better. So similarly for taxes, ask the patient to do. They know it, they do it every day, so they'll do it better than you. Simple answer. In the exam, if you're asked, this is the answer. But if you run into a fossil who's insisting, no, 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 you show me how do you do it. You may cause pain, so how does it matter? I need to cause you pain. So that is actually, I would not do that to any candidate. I'll say, just show me how would you do it in your practice. And if I was to do it in my practice, I'll ask the patient to do it. But if I have to do it, to be fair enough, remember, it's important to understand some basic anatomy rather than getting into the tab business of hernias. There's a deep ring which is deep because it comes from the innermost layer, fascia transversalis, which is formed from transversus abdominis. So the layer is from external oblique, internal oblique, transversus abdominis. Now, so it goes through the layers to come. I'm actually, if you can imagine, I can't show you here, but I come out superficially. So this is deep, this is superficial, and there is no internal oblique as a layer here, but that becomes a covering, which is a cremaster. Cremastic muscle is nothing but internal oblique in the inguinal canal. So all three layers are here. Okay. This is transversus, fascia transversalis, sorry, through which the deep ring is formed. And this is in the external oblique aponeurosis, the top layer. So you can imagine, if this is the right side, the canal has this deep, superficial, and the cord is covered by internal oblique in the form of cremaster muscle. All three layers sorted. So when you're reducing it, you need to relax it. Then it will be going from surface to deep. So it is easy. So flex the hip, adduct it, and internally rotate. You can't do internal rotation without adducting, so but it has been added. So flex the hip, internally rotate, and adduct. So the ring becomes patulous naturally because it will be made lighter. When you guide the hernia from superficial to deep, so why should it be a problem? So my one hand would be here, the other one would be facilitating this side, and it will go in. That's Texas. Now, what are the contraindications to Texas? Please pay attention. Contraindications to Texas. Now I'll change the color because I've got too much of red. Now, contraindications to Texas. First, if it is painful, never do it. Any irreducible hernia is potentially strangulated. No Texas. I'm saying irreducible hernia, sir, not just strangulated hernia. I'll take it as strangulated unless proven otherwise. I'm not going to get into this controversy of I have no tenderness, I have no problem, there is nothing wrong there, etc. That is all bunkum. No Texas in irreducible hernia. And certainly do not do what I've seen people do. This is the patient, they make a helicopter out of the patient, put end up, hernia reduced here, and one intern is sitting on it along with the ice pack to push the hernia in. Contraindicate. Don't do it. If you watched it, it's a wrong technique. Never, never. It doesn't work, first of all. So no Texas. Yes, you can give a sedative. In any case, lifting this limb up doesn't make any sense because the hernia is going into the scrotum. The scrotum would still hang. So lifting the limb up, maybe the patient can have some, cerebral edema and head injury. And if he slips, then you never know. So not to be done. I'm repeating it. No Texas, please. But if suppose I've seen it actually, if the examiner is insisting, no, it can be done. So I agree with him on that day. But you should know for future, no Texas. Texas is contraindicated in any irreducible hernia because it can be a potentially strangulated or it is an obstructed hernia. Because naturally, it's first irreducible, then it can get obstructed, then it can get strangulated. Strangulation can happen to a omentum also, so there may be no obstruction. So the strangulation is just ischemia, further leading to infection. That's the whole story. So you can give a sedative and it may reduce on its own. But the answer to any such patient presenting in emergencies, surgery, sir, there is no confusion. This is the correct answer. Everything else is the wrong answer. If the patient is not even fit for a haircut, that's a different story. The patient is fit for surgery, surgeon is fit for surgery, surgery should be done. Now, why no Texas? Why? In these cases, it is to prevent what is called reduction in mass. And what is a reduction in mass? Where the hernia is, this is the ring, this is the bowel inside. The red is the bowel, okay? So you are pushing the hell out of it like you do. Pushing it, the whole thing goes inside with the obstruction ring. So there is a whole thing inside. Now it has become black now on its own because if you allow it to be gangrenous, that is what will happen. Right, so let me use so it will be going along with the sac plus content plus the ring which is obstructed. They all get reduced. Now, therefore, and this would be a catastrophe, and it's iatrogenic. This surgeon is causing problem to the patient. So this is not acceptable because you're not following the right protocol. So in such cases where there is an irreducible hernia, the answer is surgery. Don't bother about it. Now, we won't use a mesh in emergency because we think the same thing. It's potentially contaminated, and we are not going to mess around. So the answer is we'll do surgery. Suppose it reduces spontaneously on sedation, which happens in a majority of cases, then you will observe for 24 hours. Keep the patient admitted for any signs of obstruction, because reduction in mass could have happened automatically also. This was the point I wanted to make. Now, any questions in the chat box? Now you can type. I think I can give you some opportunity now because is there any more question that they had asked?
Yes, sir. So there one question is about the surgical planning in acute abdomen. If you could kindly discuss, sir.
Whipple surgery, Prasanta Kumar Swain. I'll take that, don't worry. Any questions so far also are welcome. Now, what is the next question? Sorry.
The surgical planning in acute abdomen.
Okay. Very pertinent question. For that, you need to know what is acute abdomen. So acute abdomen, I think I've taken a video. There's a YouTube video of mine if you want, where acute abdomen is any pain which is in the abdomen, of course, lasted more than 6 hours And I've given you the definition by Sir Zachary Cope. You are aware of the Cope-Swartz test, same person, same gentleman. Now, this would be, it is lasting for more than 6 hours. It is of surgical import, which means it will require some surgical intervention. That is to be understood. So it can range from acute appendicitis to many. So I think it will be very vague. I'll probably take up appendicitis and maybe bowel perforation, peritonitis. That will take care of most of it. If there is any additional question, then I can answer. Acute appendicitis, the treatment is surgery, and there is no confusion about it. Don't just jump to say laparoscopic surgery or open surgery, or you will sing a song and appendix will come out. That is secondary. The answer is appendicectomy. And laparoscope is just a tool. It's not a specialty. So you can use the laparoscope to remove the appendix, which is, I think most of you are very clear, but you should be aware of the open, which is asked in the exam very frequently. The incisions first, the planning, sorry. So you prepare the patient for surgery. If the patient has already got a lump, put the patient on expectant treatment, and expectant treatment is not the same as conservative treatment. Conservative treatment is given by a physician. Expectant treatment is by a surgeon. The conservative treatment, that is non-operative treatment by a surgeon, is called expectant treatment. Expectant means any time you want, you can resort to surgery. So that can only be done by a surgeon. It can't be a physician doing it. So conservative treatment is truly a medicine kind of a thing, where you don't anticipate doing surgery, like expectant mothers. They're going to deliver at some point. So Oshner-Sherin regime, you're familiar with that, so I will not go in that zone. Oshner-Sherin is when you have 4-hourly, multiple Fs, fluids, 4-hourly, fasting, 4-hourly checking of the pulse, blood pressure, fasting, and frequent examination to be avoided. And then, of course, you will be keeping the patient for interval appendicectomy at a later date. A lot of people don't like to do anymore. There are studies, meta-analysis to show that a lot of them may not require surgery at all. They may be settled. So if somebody is asking you that question, you can always answer. In your recent advances chapter, it can come. The incisions, the commonly asked question is, you draw a line. This is the midline. Divide it into 3 parts. Lateral 1/3 and the middle 1/3 junction is called the McBurney's point. You make an incision here, which is a muscle splitting. You are asked a question. People say muscle splitting incision. How can an incision be muscle splitting? When you're cutting it, that is incision. So it's muscle splitting approach. Incision in the skin is not muscle splitting. In the external oblique aponeurosis is not muscle splitting. After that, you split the muscles. So the better term is gridiron. But everything works, people don't bother much about it. I'm just telling you the nuances. So it's not a muscle splitting incision. Incision is the same. Then you split the muscle and make it into gridiron. Gridiron is where you have crisscross. You have gridiron in your windows, etc. Right? So you can do muscle splitting because it causes lower hernias and muscles don't lose their strength. But that's called, some people have called it McBurney's incision. Actually, it's not incision which is at the McBurney's point, but it's not necessarily McBurney's incision. So it's a McBurney's gridiron. That is basically gridiron incision. You go through the McBurney's point, and I teach my residents to go a little lateral, just about little lateral, say 2 centimeters medial to the antispheric spine, because then they'll hit the cecum. That's our target, not the bowel. So when you hit the cecum, you follow the tinea coli, you reach them, and you just hold the cecum, and the moment you rotate it, it may just pop out. Or you follow the tinea coli to the point where it joins. That's the base of the appendix. It's easy. If the commonest position of the appendix is retrocecal, so even if it has gone places, you know where the base is. If you disconnect from there, you'll be able to get it. But this being a trapdoor entrance, you may need to make it into a muscle cutting incision, which is called Rutherford muscle cutting incision, which is done if you have to drain an abscess because you want it to drain freely, or if you have to uh, uh, extend it to go for an appendix which is higher up, or you have to do it for reaching for subhepatic type of appendix. So basically, it will be required only in very select situations. So that is the Rutherford muscle cutting incision, McBurney's gridiron incision, two most common incisions that I use. The third one is, of course, the lower midline. Now, people have modified and given various incisions. Their names say the lanes or lens, some people call it. That's instead of making it a sharp cut, they take a line in such a way that, it is cosmetically hidden under the dress. So, and it follows the line like you have the, planned incision. So that these are modifications. So that's about incision. I think that planning part and other things, I don't think I need to spend time there. I think I'll spend more time with perforation peritonitis patient. Very commonly, its workup is asked. You must, first of all, always, whenever you're answering in the exam, say, I'll build up the patient. And if you're a smarter student than that, you'll say, I'll optimize my patient. What does that mean? Well, they're usually dehydrated, so you provide fluids and some kind of a antibiotic cover, which is usually broad spectrum to begin with because you're not sure of the organism, but they need it. I'm talking about peritonitis now. They have clinical features of peritonism, which means guarding, tenderness, silent abdomen, bowel sounds are sluggish or they're absent. And usually you can have, if it's a hollow viscous perforation, the liver dullness is masked, which is a clinical finding. But sometimes it may not be masked, especially for in perforations like say appendicular perforation where there's not much of gas that comes out. And sometimes the gas in about 75% you will be able to get it, but in 25%, even in duodenal ulcer perforation, you may be not getting enough gas because it kind of leaks and then it stops leaking. So gas may not be there. And the other disadvantage of intervention, somebody has put in a needle or done a 4-quadrant tap, which is obsolete now, or DPL, then you would have introduced gas anyway, and you would not be sure whether it's the pneumoperitoneum is due to the perforation of the hollow viscous or it is caused by our diagnostic attempts or whatever you call them. So build up, optimize, that's very, very important. I mentioned this in the exam. And prepare the patient and take a good consent, including a consent for stoma. Never miss it. And it's not a bad idea to mark your stoma site so that you don't take a hurried decision and you have a high or a low stoma, and you know where you mark for the ileostomy. And ideally, you should avoid close to bony points, and at the same time, you shouldn't be getting close to the midline. And it should be somewhere where the patient can look at it and manage. A patient has a big paniculus or obese patient and it's hidden underneath, it may be a challenge. So usually the same, you draw this line, and some people like to take a midline of this and draw a cross line and they make it here. But easier to remember, spino-umbilical line, you have a, McBurney's point, maybe 2 to 3 centimeters above that. It'll be subject to the build, the patient. So basically I'm away from the antisphilic spine and I'm away from the umbilicus and midline. So you plan it beforehand. Always take that consent and plan it. And third, most of us would like to take a midline approach. I forgot to mention about laparoscopic appendicectomy, which is technically easier, and the port positions. I won't discuss it here because that is rarely asked, but you should know about it. I mean, there is a camera port, then there's one in between the umbilicus and the suprapubic, the symphysis pubis. And you may need the third one or you may not need the third one, depends upon how you're planning to do it, which will be lateral. Now, similarly here, you can put in a scope and do the procedure. Nobody is saying that you won't do, but most of us will be asking you about doing it in an open situation in an emergency. Most of us would like to do it that way. Most commonly used incision is midline, and once you've done that, I forgot to mention something when I'm optimizing. I actually got into stoma earlier. Here, I would like to score the patient. This is what we do as a routine to actually know the status of the patient's condition and whether the patient is responding to your therapy or not. Response to therapy would happen with the optimization, and we use commonly the Apache 2 score. And the planning, at least in my unit, the protocol is if it's less than 10, 11 to 20, or more than 20. Less than 10, we are able to do most procedures comfortably. We can do primary anastomosis. 11 to 20, we would like to do some kind of exteriorization, which is in the form of stoma. More than 20, this patient is not fit for surgery, won't survive the surgery. He or she will suffer from treatment. So treatment should not be worse than the disease. So what will we do in these cases that are more than 20? We will put bilateral flank drains and do the resuscitation and wait for the score to come below 20, and then we'll manage it like group 2. That's the management and that's the planning. The rest you of course know. When you get in, you can do the surgery accordingly. If there are any questions emanating out of this, I'll be happy to answer, because this is mostly what we would be doing in these cases. Before I go to the Whipples, any questions so far? Because I've covered the questions that were pending for a long time. So if you could write in the chat box. Now coming to Whipple surgery, that is being asked by Prasanta Kumar Swain. Procedure practically, okay. You would be doing Whipple's procedure for periampullary cancer or head pancreas, carcinoma head of the pancreas. And most of these patients are with obstructive jaundice. So needless to say, I'm not getting into preoperative preparation because you just want the operative technical aspects. Preoperative preparation is, in any case, I'll quickly sum it up. Optimize in the form of fluid, electrolytes, and here it's important to manage nutrition. Third is adequate hydration is important to prevent hepatorenal shutdown. Nutrition, you would have done it already. Parenteral, preferably enteral, if the patient could take orally. Build up this patient because they're usually depleted of the glycogen stores in the liver. And third is their coagulopathies, which are likely to happen due to no vitamin K being there and liver being compromised. So you'll have to correct this, and importantly, preventing sepsis. So they'll be on some sort of antibiotic prophylaxis. Having said that, there are also situations where you have to do biliary decompression preoperatively. Not recommended as a routine. It's only done if there is septic cholangitis, or if the patient has intractable itching, for which your surgery in any case is delayed. Now, delayed surgery can be if the patient has been put on neoadjuvant chemotherapy also. So, patient on neoadjuvant chemotherapy, delayed surgery, etc. Sometimes, whether you like it or you don't, if the patient has gone to the gastroenterologist first, they put in a stent. And that can be good and bad at the same time, because technically, post stenting, the anastomosis can be a technical challenge. There's a lot of fibrosis there, although the duct looks firmer and takes a bite, but the blood supply is compromised, and sometimes that can be the cause of pancreatic leak. Now, so we have done all this. I've quickly taken you through. Don't ask me the details of this part because this is very important. It's asked in the exam. Now comes the role of you are in the operation theater. Patient is supine. And most people would like to have a block or something that anesthetist would like to give on their own. The first thing is whether we do diagnostic laparoscopy or not. I call it a staging laparoscopy. It is done in situations where the marker is high. You know which one I'm talking about, you can answer in the chat box. I'm leaving some question for all of you to answer. That's where you would like to do that. And in addition to this, it is a CT, even if you've done the best CT, it can miss the peritoneal mat. So in a doubtful case or a borderline case, which you have, taken up for surgery, ideally it should be on neoadjuvant chemotherapy, but suppose you have put in a scope, it can pick up the peritoneal mets. And sometimes you have mild ascites, which is not always due to peritoneal metastasis, because they also have hyperproteinemia and also some bit of portal hypertension can produce that picture. So in these cases, you can actually make sure that there are no peritoneal deposits, and you know that laparoscopy can pick up smaller than, the ones that you can pick up on CT. When you're in 1 centimeter, they say 1 millimeter, they say 5 millimeter, they say. So it keeps varying. But even in the best of, even if you're using a helical CT, you're likely to miss. So staging laparoscopy is done in these cases, and then you go in for surgery. Now, steps of surgery is what you were actually asking. I gave you a quick overview of the other steps before I went in for the surgery. You open through the midline. The first thing you need to establish is resectability. Although you are already sure of based on imaging and you've already planned it beautifully, and you should be very, very closely working with your radiologist who should be able to guide you into the various zones and resectability, etc. You open to the midline. Now you have, obviously, you'll find a distended gallbladder. Exclude metastasis. Yet again, any imaging, you don't treat the X-rays, you treat the patient. And the imaging is diagnostic, but it is not the treatment. No, I'm using another color so that you're able to see this better. That's your lesion. So first step is, a lot of people like to do cauterization after they've excluded everything, right? When you cauterize, what is an optimum cauterization? You keep going medially till you see the left venal vein, which is opening into the IVC. So you cross and very far. And some people like to do a cattle brush, which means you mobilize the colon as well. So the whole thing moves. You're able to get a good retroperitoneal lymph node clearance. Some people believe that. Most of us like to do a good cauterization. We reach up to beyond the point where you can see the left renal vein. The next step is to look for whether it is resectable or not. You all know that. Splenic vein and which vein will join to form the portal vein? Superior mesenteric vein. You're right. So we'll look for, that's the pancreas, that's uncinate here. And you look for the space here by introducing either a Kelly or fine dissection. Some people introduce a finger from above as well as from below to see whether it's clearly dissectable or not. But a lot of us would like to pass in a tube. A stiff tube can actually let you know. So this is to roughly know again that you are able to dissect it or not. Once you've done that, you're a cauterized pancreas. Then rest is simple. Once you've got it, you have to go to the upper side now. You've got to do the cholecystectomy, and we get the common hepatic duct transected here. We follow it down. Then we introduce from above and below. We find that it is resectable. Once it is resectable, we like to take it on a, the pancreas is free from disconnected in a way that, a lot of people do it differently now at this point. They may disconnect it, the head, and then when you open it up, this is the hanging method. You can see the small tributaries that are individually ligated or clipped. And the challenge now is to get the uncinate process freed, which is where the positivity happens. The R1 dissection happens usually there. So you should be very careful in making that dissection happen. The distal pancreas is disconnected, but when you're disconnecting it, a lot of people like to take stay sutures in the form of so that they are able to. So this is the pancreas. Suppose they taken stay sutures, or they tie it up so that there's minimal bleeding. And you can cut it with a diathermy, and a lot of people will use harmonic scalpel. But the important thing is to be sure the moment you come close to the duct, and we cannulate the duct so that we can have the duct always available to us. Now, this is the part which is going along with the uncinate, and this is the part which is going to stay. So we cannulate and disconnect it. So we have the body and the tail on one side. Most of it is, you get a clear margin there. And then it's kind of opened up. So you're able to dissect the vein and the artery from the pancreas, the uncinate process, especially tie all the tributaries. Tributaries coming from the pancreas. There are multiple tributaries, and right angle is a very useful instrument to hook them out, clip or tie, clip and tie, clip and tie. All important vessels must be tied. And below the pancreas, you find the straight artery going. That's a gastroduodenal artery. You know that you've got a good clearance. Once you've done that, so pancreatic or duodenectomy would happen. You would have disconnected from close to where there's a ligament of Treitz and part of the stomach. This entire thing is removed. Where am I? Yeah. So you'll have a part of the stomach, which is not a pylorus preserving pancreatic duodenectomy that I'm talking about. And then you have the jejunum. And then you have the common hepatic duct. Everything else is gone. Right? So we'll take either a roux loop, or some people like to just take the loop up to the hepaticojejunostomy, gastrojejunostomy, and this is the pancreas, which is lying here, and duct to mucosa anastomosis. A lot of us like to perform, and then you can do some bit of dunking here. The other option is you can put it into the stomach, and you can actually cannulate it, bring it out like you have a feeding jejunostomy. You can have a stent, like a feeding tube can be put in through. Some people stent it, some don't. It depends on your practice and also what you've been trained to do. And this is the most crucial anastomosis. Along with that, always this is the part which will go up like this. I mean, I'll show you again because I don't want you to get confused. Now the jejunum was free, so it can be taken right up, closed, and you can have the duct anastomosis. This is happening here, and the pancreas duct to mucosa happening here. So this is how it will finally end up, and we'll have a, that this tube can come out and acts as a stent, and we can do a feeding jejunostomy, which we must do. We do it in all the cases. That is the Whipples as quickly as I could possibly cover. So if it is clear to you, you'll have to type yes, Prashanta, and do type in the chat box. If the answer is any question there, you can ask me. I hope you're there, Sven. You asked the question and I hope you didn't disappear. Please type in the chat box if you got your answer. Okay. Amir, you got it, but Prashanta, you asked the question, so you should be writing it. Okay. Sequence of anastomosis. Good. What I do, I'll tell you. My principle is what I cut first would happen automatically last. So, but I'll make it easier. There's no hard and fast rule. People have their own ways of doing it. So first I'll do hepaticojejunostomy. Because I would take, what I do is I'll take this, now the jejunum is free. I'll free from the ligament of Treitz. I cut it. This is the free segment to me. I'll just take it out. and I'll anastomose it with the hepatic duct. The same loop is coming down, stomach, pancreas, done. And PDS 4O is what I use. Extended Whipples is when you go beyond the the head, you may take a part of the body. And if it is possible, a lot of people like to do the pylorus preserving, a specific situation where you can core it out. I mean, if you cannot core it out, then it's a challenge. So hepatocogenostomy, gastrogenostomy, and last pancreaticogenostomy. What my mentor used to do was pancreaticogenostomy first, because that's what he will do, and then he leave the two for me to do, because that's the most important anastomosis. So it is optional. I do it in one flow, so it's easier. The loop then keeps coming down. I find it easier that way, so it's optional. There is no way it can be other way around, Prashanta. It is end to side all the time, except if the hepatic duct is so huge and jejunum is going to be there. But it's if I can say all the time it's end to side, it won't be wrong. I mean, there's no way. I remember a duct which was as large as the jejunum, and it could be done to end, but that's not what I would fancy doing it. I've seen it being done. So what I'll do is I'll close it with a staple. This gets closed. I mean, this gets closed here, and then I have an anastomosis done. My hand is going the other way around. So I'll show it here. This is exactly what I'll do. This is closed or stapled. Anastomosis here, anastomosis here, anastomosis here. All end to side. 4O PDS. I'll tell you one thing. I've also used Prolene when we use dunking. I have found that very useful because it slides well. But that was in the days when PDS was not available. Presently, PDS works and behaves like Prolene only. Is it must to do cholecystectomy? Yes, because it is a static bile. Must be a contaminated gallbladder. What are you going to do with this gallbladder? Hepatic duct. It is. I mean, I'm just drawing it for you to understand. What are you going to do with this gallbladder? This has no function. So I would prefer to, if I have to anastomose at the level of common hepatic duct, what option do I have but to remove this entire thing? No. Even when I have to do the triple bypass, I always do it to the common hepatic duct. Rarely in those cases where I want to be quickly out or it's not comfortable cholecystogenostomy. So, okay. So Ahmed, you have used Prolene, good. I've used it. It's very good. It slides through very nicely, and I like it. PDS is also a very good option. Common complication. One complication is, see, the dreaded complication, if you're asked, is a pancreatic leak. Others are for any surgery. They are not a big deal. And you know what? I used to, since the nasogastric tube is in the stomach, right? I'll be able to see whether eventually when you have a situation that the bile is coming in the nasogastric tube, I'm satisfied because that means my hepatocogenostomy is intact. The gastrogenostomy almost never leaks because the supply is so good. The issue is with the pancreatic leak, and a lot of people don't stent it. If it's a soft pancreas and the duct looks friable, it's not a bad idea to put the patient on octreotide beforehand, before the fistula develops. And it works very well. It keeps it dry. So there is a case for prophylactic octreotide in soft pancreas, and this happens usually with the duct with the stenting. And with the stent, there's a lot of fibrosis. These are the ones which are likely to leak. Or if the duct is very tiny, and I've done dunking. So it's much better to put in a feeding tube as a stent. It works. So these are various ways. But the major complication is, I would say, pancreatic leak. Second is hemorrhage. People ignore it, but it can be. And the rest is any anastomosis leaking will produce its own issues, and you must have a scan the patient and run a scan on 48 to 72 hours. But if the patient is stable, there is no reason. And of course, there are procedures, whether those that are related to DVT, pulmonary embolism. These are the common ones with any prolonged surgery. We should not let the patient be hypothermic anytime. Hypothermia must be prevented in all prolonged surgeries, because that leads to many other complications that are related to it. Usually so softness of the pancreas determines the leak rate. So I think that takes care of it. Most of the parts are now covered. If there are any questions, is there any, just as Chetan, where cystogenostomy is preferred over cystogastrostomy, drainage of pseudopancreatic system? Okay. Cystogenostomy Chetan, the common surgery is cystogastrostomy, because if the cyst is indenting in the posterior wall of stomach, it's easier to do. The second advantage is you can follow it up with a upper GI endoscopy anytime. But if there are multiple cysts, not adjoining stomach, then you prefer cystogenostomy, because you have no chance otherwise. So learning, sir, portal vein or mesenteric vein repair added by user. Still it's theoretical. Got it. Okay. So cystogenostomy, cystogastrostomy. I don't understand the question, Amar. Portal vein or mesenteric vein repair added by you. Okay. If you are looking for, if you can up to 2 centimeter, they say, of the portal vein can be repaired if you are able to get R0. And if you're repairing it, you can use a graft. It can be used, PTFE or any graft. You will have to, it's better to involve a vascular surgeon here. Same is applicable to vein. So basically, these are very, difficult cases. And it is also not common for such cases being taken up upfront for surgery. You would have known by imaging. Now, imaging is very thoroughly done, and you must spend some time with the radiologist to learn exactly the position and take a decision based on imaging. So such patients may require neoadjuvant. Marky, sir, is it not depending on the size of the cyst we plan? No. Size has nothing to do with it. Actually, I'll tell you why size won't matter. When you decided to do internal drainage, you're just looking for a viscous. If there are multiple staying away from stomach, what choice do you have? You can do multiple anastomosis. If there's one indenting the stomach posterior, you do the cystogastrostomy. So that is where size won't matter. Fowler's operation for undescended testis, and how can the testis be while after lighting? Because testis has dual blood supply, cremasteric and a testicular. You ligate it and you ligate it and you leave it for its supply, depending upon what you're planning to do. So when you ligate one, the other one would be, able to sustain it. And it's like delayed flap if you do. No, it has two supplies, cut one so that you can then lengthen it. So that is how you would, suppose you clamp this it will be depending only on this, no? But once you've moved it, you can take the testes now. That is the Fowler-Stephens approach. Right. So if the portal vein is involved, don't be just to triple bypass. No, I just mentioned, you didn't listen carefully, Marky. Pay attention. I said it is advanced disease, but if you can get a clear margin and the length is less than 2 centimeter, they can do resection and reconstruction as long as you're getting an R0 resection. So this is, the best treatment for pancreatic cancer is surgery. So triple bypass is not equal to Whipple's in terms of the disease-free and overall survival. That is why, Marky, where possible, and if you can incorporate involved, it's an MDT decision. You have to plan it beforehand. You can't decide on the table now that I find that portal vein is stuck. I can't just chop it off. Portal vein, I was mentioning how much can be reconstructed. You can't reconstruct beyond maximum 2 centimeter, which is very small, so that you get a clear margin. And portal vein could be just abutted or involved. Involved would have a thrombus, a tumor thrombus inside the lumen. Okay, so I think with that we can close it, unless there is any question. And I hope you're all there for the scrubs. We are planning it in January first week. And we'll try to have 5 days of thorough case presentations, which are beneficial for students. It was planned in such a way that, your exams would be taken care of. Harsh, it's a direct message. Sir, is feeding genioscopy close itself when we remove the feeding tube? Yeah, it tries to seal off. We don't have to repair it. That's correct, Harsh. Now we due to COVID the limitations, the auditorium that we normally use, the permitted numbers physically attending, because now there are most meetings happening physically, it cannot go beyond 120. That's why we have mentioned. You can join on, last time we had 1,000 plus students, so we can't have everybody there physically, but it's more useful. So it is possible to attend it online. Unless you're registered, you can't attend it online or offline. So the first thing is to register. And the second thing is to try for the physical attendance, because it will be beneficial for you. For those who cannot come, genuinely those who are away outside the country or who are outside far away, and traveling is a risk. That's why we kept it hybrid. We might increase the numbers, but that's the limitation right now. So 125 is the maximum we can take. And as always, those who register, they have an access to the course. And this time we'll try to keep it in such a way that you can actually watch it. But register. Unless you register now, it's not later date that you can get it. Whosoever is asking. So if you're all okay with it, can we close it now? And let's get your feedback as to whether you learned, it benefited or it did not. Because I tried to just take up the old questions. Some of them I was trying to cover up. So could you write in the chat box, and then I'll get an idea that we can stop it. Now, should we close it? Thank you, Prashanta, Marky, thank you. Don't be lazy about attending scrubs later or not attending now, etc. That's your take. We'll always have a house full, but make the most of it. We'll try to introduce one day to dedicate it to how to actually crack. We'll set up examination scenarios this time. Well, thank you all. I'm so happy that it made sense, and I'm glad that you enjoyed it as much as I enjoyed getting it to you. So, bye-bye. Take care. Good night. Thank you.